Good evening. The topic for today is epidemiology, and the doctor we have here is Dr. Naveen Kumar MS. He is a senior resident neurology at JB Pant Hospital, New Delhi. Sir, you may take over.
So you are appearing for part one or part two, can I know? I'm Dr. Naveen Kumar. I'm working as a senior resident in GB Pant Neurology Department. So I have completed my Mrcp 3 years ago, and I have completed my USMLE as well. So I'm post MD medicine. So I want to just know about you. Just type whether you guys are appearing for part one or part two, or is it preparing for simultaneously?
Part 1, sir.
Okay. So there, there will be around we can expect around 10 questions in part one, and it will be very simple. Like you will be, these are the subheadings in which the questions will be asked. So the first questions will be it will be the very simple question. The topic will be a measures of disease frequency. You will be asked to calculate the incidence and prevalence, the mortality rate. So the second one will be the types of study. So you will be given a study format and asked whether to identify whether it is a case control or a cohort or a randomized control trial. And after that, you will be asked to calculate the risk and effects. So you know the relative risk odds ratio. And then you will be asked about the statistics test, the chi-square, the t-test, ANOVA. You will not be asked about the exact formula or the details, but they will ask you what test will you apply to find the significance in this, whether it is a normally populated curve or a categorical value. I'm just giving an overall idea, and I will dive into the individual topics later. The next topic would be the confidence interval and the p-value, type 1, type 2 errors, and the graphs and interpretation, survival curves, and forest plots. So you can expect around 10 questions. Mostly it will be a simple question, and they will not be expected you to use multiple formulas. You just know what is the formula used for the statistics test, but you will be asked to calculate the risk and effects, odds ratio, and relative risk. So can anyone say why do we do a clinical study? Hello.
Aspirants, please answer. Please, you can unmute your mic.
Why do you want to do a clinical study? Am I audible?
Please, loud, please.
Am I audible?
Excuse me, voice should be slightly raised.
Am I audible?
Yes, sir. Yes, sir.
Sir, can you see, did you hear what I said?
Yes, sir.
Okay. So see, why do we do a clinical study? Just say me some salient features like why do we do it? Because the most of the clinical studies give the evidence to practice. For example, if we are bringing a new drug, to know whether the drug is actually working or not, you have to do multiple studies from a small population. Then you increase the size of the population to find the efficacy and the side effects. So to know whether the drug is going to work, you start with what is the association and the causation. For example, the studies are divided into observational study and the randomized control trials. See, in the observational studies, you just observe the analytical studies, observational studies and analytical studies. The observational studies are further divided into analytical study. The analytical study consists of a case-controlled, cohort, and cross-sectional. Whereas the treatment, this is called treatment studies. So these are divided into randomized clinical trials and non-randomized control trials. In each of these studies, we obtain evidence. For example, in a cross-sectional study, we do study at a particular point of time. So what we will do is that we will go into the community and we will do a house-to-house survey about what is the whether they have diabetes or not. If that is, we are doing about a study about diabetes at a particular point, it is a cross-sectional study. We try to understand the the prevalence of the disease in that particular community at a particular point of time. So that is a cross-sectional study. But the problem with the cross-sectional study is that the cross-sectional studies are done at a particular single point of time. These will give only about the prevalence and not the incidence. For example, if you go into the community and ask the population about whether they have a diabetes or not, it is going to give you the prevalence of the prevalence of the disease. What do you mean by prevalence? What do you mean by incidence? So prevalence is defined as the what is the number of patients have that particular disease at that particular point of time. For example, if you go to a village and see there are 100 patients having diabetes, it is prevalence. So we can say that the prevalence of diabetes is 100. The incidence is calculated over a point period, like over a longitudinal follow-up. For example, you go to the village every month and then you start in the month of January, you see there is 100 patients with diabetes. Now this becomes a prevalence. Then you go on February to the same village and you calculate. Now you see that the incidence of diabetes, the prevalence of diabetes is 110. So meaning there is 10 new patients have been added. There are 10 new diabetic patients. So now this becomes incidence. So if you ask the incidence is 10 per month. So the incidence of diabetes in that particular village is 10 per month. So usually you say it per month or per year, depending upon what you want to interpret and what is the question being asked. So the idea is that the incidence and the prevalence are two different terms, and the prevalence is it is at that particular point, while the incidence is calculated over a longitudinal follow-up. So when you do a cross-sectional study, you go and do the data and sample analysis at a particular point of time. That is a single point of time. So only you can do is prevalence and you cannot find the incidence. So once you go into a population and there is you get an information that a patient is having loose stools. So now you go to the village and you do a study and you go to door-to-door survey and find out that there are 100 patients or 100 population people are having loose stools. Now you calculate the other data. Like what is the other data? You calculate the age, sex, and what is the working condition and whether they have home cooked foods or they eat outside. So then you found out that most of the patients who developed loose stools were eating from outside hotels. So does that prove that the eating outside is the causation of this 100 loose stools? We cannot prove the causality. What we can do is that we can see the association. For example, we can say just that the patients who develop loose stools, they were eating outside in a hotel. This is called an association, and you cannot prove the causality. To prove the causality, you have to do the other studies. So that comes because you cannot prove the temporal relation between the exposure and the outcome. So you don't know whether they had the food in the hotel. After 2 days, everyone developed loose stools, or only 50% of the people who ate the food in the hotel developed loose stools. So this cannot be proven. So the temporal association cannot be proven. So we need further studies to prove the causality. So in the cross-sectional study, what you can do is that you can only measure the prevalence, and association, you can get the association, but you cannot prove the causality. So to prove the causality, you go into the other studies. I'll just come back into the this thing. So I'll just touch upon what is incidence and prevalence. So assume that it is a water tub. Okay. See, this is a new incidence. Incidence is that what are the new cases you are getting in that particular community. So once the incidents are piling up, this becomes a prevalence, because prevalence is like that during that particular point of time. So when can a prevalence decrease? Once you find a new drug and you treat the disease becomes cured, then the prevalence is going to reduce. The prevalence is going to reduce when you have a cure. When the patient dies of the disease, again the prevalence in the community is going to decrease because the mortality is increasing. So the mortality will reduce the prevalence, the cure will reduce the prevalence, and if the patient is having a recurrent disease, recurrent loose stools, then the prevalence is going to increase in the community. So incidence will definitely influence the prevalence. Whenever the incidence is increasing, it will increase the prevalence. Whenever when you have found a cure for that particular disease, the prevalence is going to decrease. When the patient dies very soon, maybe because the patient is having corona and the patient is dying fast, though the incidence might be high, the prevalence tend to decrease because the mortality rate is very high. So this is the difference between incidence and prevalence. So how do you calculate the incidence? So incidence, you have to do a follow-up study. Like you have to follow up the particular community every month. Only then you will know that whether the disease, what is the frequency at which the disease is occurring. So the next studies we are going to discuss is the case control and the cohort studies. So cohort study, see in the cohort study, what we will do is that these are the kind of observational studies. So what we will do is that you select a particular, this will be the population. So you select 100 people from a village. Now you divide those people into 50-50. Let us assume that these 50 patients are exposed, they are smokers. And these 50 are non-smokers. So you have a cohort in which 50 patients are smoking and 50 are non-smokers. Then you tend to follow up for a maybe around, we follow it of 10 years. Then you see among the smokers, how many are developing cancer plus and how many don't develop cancer negative. Among the non-smoker, again, you follow for the same time period and you found out how many develop cancer and how many don't develop cancer. So you're following up, you take a particular sample, you divide the sample into based upon the various risk factor, whether it's a smoker or a non-smoker. Then you follow up the patients for a while and then you develop and you see whether they're developing the disease or not. So this is called as a cohort study. This is called a prospective study because at the time when you start the study, the disease has not yet occurred. So only the exposure is present and then you follow them and you find out what is happening to the patient details. So this is called as a cohort study. Since you're following up these patients for a long period, for a period of time, you can see that how many patients are developing cancer. So this will give you the incidence. So let us assume that out of 100 people, among 50 smokers, let us assume there are 10 new cancers here. So what will become, there will be, the incidence will become 10. So this is how you calculate the incidence. So for calculating the incidence, you need to have a follow-up of the patients. So the incidence can be calculated from a prospective cohort study. Like you need a cohort study to calculate the incidence of the patients. So what exactly can you prove apart from the incidence? What can you find apart from incidence is you can prove the causation because you know that you are dividing the patient into two groups, that is smoker and smoker. So you are very well sure that these people are developing cancers and these people are not developing cancers. In case if you think that the smokers tend to develop cancer more than the non-smokers, now the causality is established. So to prove a causality, you need a cohort study. That you cannot do with a cross-sectional study because the cross-sectional study is at a particular point and you're not following the patient, so you're not sure about the causality. So this is the prospective cohort study. So there is something called as a case control study. So what is the difference between a cohort and a case control? See, in the case control, what happens is that, let us assume that you are working in a hospital. Now the patients, there are some mesothelioma patients are coming to you. Let us assume there is a mesothelioma patients are coming to you. There are 10 mesothelioma patients have come to you. Now you are confused in what you want to know what is the cause of these mesotheliomas. And you know that this disorder is very rare. So now what you do is that you get these patients and then you ask the multiple history. You go back in time and ask the history, what were you doing and what were you establishing, what's your work, or were you a smoker, have you worked in a shipyard building industry? Now the people among this 10, they will say that they will say that, yes, sir, I was working in a shipyard factory. Let us assume that I was shipyard factory, I was working. Some people around this 10, 8 people, let us assume that 8 people are saying that I used to work in a shipyard industry. 2 are saying that, no, sir, I have never worked in any shipyard industry. I was working in agricultural fields. Now what you do is that you go back in time, then you try to analyze what caused the disease. So this is called as a case and control. At the simultaneously, when you get a case, you get a control. So what is a control? Let maybe assuming that in the same hospital, you are getting 10 more patients of assume that they are getting a liver cancer patients. Now this can be controlled, or you can take a normal healthy controls as well. Now you go back in time and then ask whether did you work in shipyard industry. Now they say that they said यहाँ पे what they will say is that mostly they will say that no sir, we only one people have worked in the industry, shipyard industry, and 9 will have not worked in the industry. Now from this what you can say is that the patients who work in shipyard industry tend to develop the disease mesothelioma more common, more frequent than who didn't work. So this is called as a case control studies. Now the problem with the case control study is that the patients will tend to forget a lot of information, like what for the timing they were working, how many days they worked, did they get an off. So the exposure is not very clear in the case control study. Though there is, you can have that this might be causing the disease, you cannot prove it. Again, the causality, if you want to prove case control study, you cannot prove the causality. You need a prospective study or a randomized control trial to prove a causality. You can see association, yes, you can see this. So now this is going back in time. So when can you do a case control study is that when you think the disease is very, very rare, so that you cannot, you cannot do a cohort study. Then you do a case control study. So there is another study which is very confusing, similar to a case control study. That is called as a retrospective cohort. So what happens in a retrospective cohort, though it is a kind of cohort study, now I have this, let us having this is a mesothelioma. Let us assume some other disease like for an HCC. There is the new. Now what I will do is that I will go and visit the healthcare record. Let us assume that there are patients who had hepatitis C positive, hepatitis C negative. I'll go to a hospital registry. Now I will say I will divide the patients into two groups based upon the hepatitis C status. So I will group one into hepatitis C positive, the other group into hepatitis C negative. And then I will see how many of them developed hepatocellular carcinoma and how many of the hepatitis C negative didn't develop hepatocellular carcinoma. Now the disease has already occurred, but I am not going from the disease to the exposure. I'm going back in the time. I go to a data and I check whether I will see the hepatitis C positive, hepatitis C negative, and then I will tend to see how many of the hepatitis developed disease, how many didn't develop disease. So disease positive, disease negative. Now again I will see disease positive and disease negative. So this is a retrospective cohort. This is very confusing with the case control study. In a case control study, what we do have, you go back mesothelioma, let us say mesothelioma. You just ask the patient themselves, what were you working? And then you say that then it becomes a case control study. But in a retrospective cohort, you don't ask the patient, you go to the registry back and you subdivide the groups into hepatitis C and negative, and then follow them up what happened to them. So going back in history, and then you are analyzing it. So this is a retrospective cohort. So these are the studies which you. Okay. So I'll just recap about the case control study. It is a retrospective study. So what you do, you go back in time, then you compare individual cases without the disease. So for example, mesothelioma, you compare patients with mesothelioma and those without mesothelioma, and you go to ask history. What was the prior exposure? Now the association, you can see, I told you that proving a causality in a case control study is difficult, but you can estimate the association. So the association is estimated by odds ratio. So I will let you know how the odds ratio is calculated. And then you cannot calculate the incidence or risk directly. And they are prone for recall bias and selection bias because they tend to forget what happened in the past. So you cannot establish then you have a recall bias and a selection bias. So you cannot establish the causality, you can only establish the association. So coming to the cohort study, it can be prospective or it can be retrospective study. The groups are compared based on the exposure. So for example, if you want to give a simple example, I will divide the strata into smoker. Then I will divide the patients into non-smoker. Then I will see follow-up who developed cancer, who didn't develop cancer. यहाँ पे also I will see who developed cancer and who didn't develop cancer. Then I will analyze it. Then I will get a risk, relative risk. So this establishes the temporal relation. So now this proves causality. So cohort study, you can prove a causality. And what are the problem with the cohort study is that it is very time consuming because you have to follow up the patients for a while and it is expensive. And it is less prone to a recall bias because you are doing it in a future study. You are following up the patients, the chance of bias is very, very less here. So, I have discussed this. So I'll just see the difference. So when do you do a case control? When the disease is rare, you do a case control study. And then it is retrospective. It is faster and cheaper. You do an odds ratio. While you do an relative risk in cohort study, and you can measure the incidence. Very important. So to measure the incidence, you have to do a cohort study. To measure a prevalence, you can do it from a cross-sectional study alone. So it is more prone for bias. It is not prone for a bias. So I will ask you this. Okay. So can anyone say what is the kind of study? What is the study? What are you trying to do? Just read this alone. And can you say what is the study? Whether it is a case control study or is it a cohort study? Anyone?
Case control.
So why are you saying it is case control?
We are asking the history of smoking. We are not
Exactly.
following up the patient.
Yeah, you're going in retrospective. By when the study started, the patient already had lung cancer. Now, after having the lung cancer, you're going back in the history to ask whether they had a history of smoking or not. So this is a case control study. See, the formula for odds ratio is that you find what you do is that you divide the incidence of lung cancer in the smokers. So lung cancer in smoker divided by lung cancer in non-smoker. So once you get this ratio, you have to divide this by lung cancer in no lung cancer in smoker divided by no lung cancer in non-smoker. So when you simplify this formula, the lung cancer in smoker I have represented in the table as A. Lung cancer in non-smoker, it is represented as C. The lung cancer in smoker is no lung cancer in smoker is represented by B, and no lung cancer in non-smoker is represented by D. So this is the formula A by C by B by D. So once you simplify the formula, you get a cross product. Matlab, it's very easy. A, D, you multiply this AD and you divide it by BC. This is called as a cross product. You might be asked to calculate the odds ratio. It's very important. So you try to understand. So what will you do in this? You have to put the disease here. So this is the disease column. You don't put the risk factor here. So the disease plus, disease minus, risk factor plus, risk factor minus. You just see the table how it is formed. If you interchange this, then the B and C will change. Then you will lose the, you lose this question. So once you get a study, if it is a case control study, you put the lung cancer disease here and the disease positive status in the first column, the disease in the second. Okay. So I will just give you some examples for you to calculate. So once you get an odds ratio, you calculate whether it is greater than 1 or it is equal to 1 or it is less than 1. If you have an odds ratio of 1, what does it mean? That the odd of exposure are greater in the cases. So meaning that the odds of the lung cancer patient being a smoker is higher than he being a non-smoker. So this is how you have to interpret the case control study. Okay, any doubts? Just let me know. Please stop it then and there because it's a bit confusing, case control and cohort. So I'll just move on to the next slide. So anyone can say what is this? What is the kind of study? I have given a similar risk factor in a similar disease. So what is the study here?
Cohort study.
So why are you saying it's cohort?
Because we are following it for next 10 years.
Exactly. So one, you have divided the group into two groups. You have divided the group into smokers, and then you have divided them into non-smokers. Now you have followed up to see whether they are developing lung cancers. Lung cancer plus minus. They are doing the same thing here. Lung cancer plus that is minus. Since you're following up, it becomes a cohort study. So the main aim of the cohort study is you can prove a causation and you can calculate the incidence from this patient. So how to calculate the relative risk? So the relative risk is given by the formula. Relative risk, what you have to do is what is the incidence? I have told you that you can calculate the incidence from the cohort study only. So you divide the incidence of cancer in smoker divided by incidence of cancer in non-smokers. So if you rearrange the formula I have given again, the disease comes here. This is the disease status. This is disease positive. Disease negative. This is the risk factor, positive and negative. So what does A denote? A denotes that incidence. The formulas again goes like, so how to calculate the incidence of smoking? So I will divide the incidence A by the total number of smokers. So total number of smokers is A plus B. The total number of smokers is A plus B. So the incidence is given by the formula in the smoker is A by A plus B. While the incidence of the cancer in non-smokers is incidence of cancer in non-smokers. So incidence is C divided by non-smoker is C plus B. So you divide C by C plus D. So this is the formula. So A by A plus B, then you divide it by C by C plus D. So this is the formula for relative risk. So once you get a relative risk greater than 0, it means that the exposure is associated with the disease more. It can cause the disease. For example, if the relative risk is greater than 2, this is equal to 2, then you say that the exposure is associated with, it can increase the incidence of cancer by 2 times when compared with the non-smokers. So this is how to calculate the relative risk. So you have to know the formula for calculating the odds ratio and relative risk. So when the ratio is 1, you mean that there is no association between the disease and the incidence. When the relative risk is less than 1, it means the inverse, that the exposure is associated with decreased disease occurrence, meaning that it is protective. Okay, so I will just recap the difference between the case control and cohort. The case control, you will be calculating the cross product AD by BC. So this is the simplified formula. Just remember this. Odds ratio is AD by BC. While the relative risk is a bit complicated, you have to calculate the incidence in the cancer group followed by the incidence in the non-smoker group. Sorry, in the incidence of lung cancer in the smoker group, you divide it by the incidence of lung cancer in the non-smoker group. Once you get the ratio, you get the relative risk. Okay. See, the establishing the causation is not very simple. Okay. There is a criteria to prove the causation. So, for example, if you say that smoking is causing lung cancer, to prove the causation, you have to fulfill all these criteria. So the most important criteria among all this is the temporality. What is temporality is that if the patient is developing a lung cancer, he has to have started smoking earlier than the lung cancer, before the lung cancer occurs. If you say that smoking is causing lung cancer, he should have smoked before the incidence of before the diagnosis of lung cancer. So this is the most important criteria for causation. So this is the criteria. You don't need to remember everything, but if the question is asked what is the most important criteria among to prove the causation, it is temporality. If the temporality it is not there, then you cannot prove the causation. See, what are the other criteria which help to prove the causation is strength. For example, if this, what is the strength? For example, if you're smoking more cigarettes, the incidence of lung cancer is increasing, then yes, the strength is there. What is consistency? If many smokers are developing lung cancer, yes, there is a consistency that smoking is creating, it is causing the lung cancer occur in different population and different studies. Consistency. What is a biological gradient? If you smoke more than 40 cigarettes per day, if the lung cancer incidence is increasing, then it is a dose response. It is not the most important criteria, but temporality is the most important criteria. People do confuse the biological gradient. This is the most important criteria for causation, but it is temporality. So remember, so these other four are not very important, but just you can understand from the definitions. Like experiment, if you are reducing the smoking, then it will reduce the incidence of lung cancer. Then that is one of the criteria. And then coherence, like plausibility is that you identify a carcinogen from a cigarette, and then you have proved that this agent is causing lung cancer. Then you know that okay, smoking can cause lung cancer. So these are all of not less. It is a less stringent criteria, but the temporality is very, very important to prove causation. Okay, so I will just say what are the disadvantages of an observational studies compared with an auto. To prove a causality, observational studies are okay. So you do a cohort study, you get a causality, but still it is not controlled. It is not a very well uh, formulated study. Still, there is a drawback. So you need another study to prove it. There is a lot of risk of bias. So I will explain what is bias. Okay. So before this, is there any doubt in case control versus cohort studies? Just let me know. I can read it again. Is there any doubt? Just let me know. Can I move to the other topic, next topic?
Yes, I believe that aspirants have no doubts yet. So you can proceed.
Okay, if my pace is, if I'm fast, let me know so that I will slow down a bit. Okay. So I'll just start with the topic of biases. Okay. So there is a lot of problem with these studies. Okay. So there is this bias. So for example, is anyone having doubt? I can hear some voice.
Aspirants, it's a request to kindly unmute your mic and please, if you have any doubts, please come up with it. And also, please keep your mic muted so that we have unavoidable session. Thank you. So you may proceed.
Okay. See, what is bias? Bias means that we are favoring one over the other. When you're conducting a study, you should never favor. You assume that in the beginning of the study, everything is same. But there are some fallacies which tend to favor one of the disease or the variable. Okay. So what is a selection bias? So once you're doing a study and then you're selecting a patients without any proper schema, then you tend to have a selection bias. For example, there's a systematic error in participant selection. So for example, I told you as a case control study, where do we get the cases? It is mostly in the hospitals. So what will you do is that you tend to recruit the control from the same hospitals, because that is very easy to get from the hospital. So once you recruit the case from the hospital, and you also recruit the control from the hospitals. Now, problem is that let us assume that this control can be, so what is the case if you're taking it for lung cancer? The cases are lung cancer. These are the cases. And anyone without lung cancer will become a control. But if you take the control from the hospital, they might not have lung cancer, but they might have something else. For example, they might have a tuberculosis or any other lung injury, which will tend to shift the study towards a fallacy. Like you cannot know what exactly is happening there. So this is called as a selection bias. So how will you reduce this bias? So now there is something called as randomization. So how it is randomization is that, so once a patient is coming, then if once a patient is coming, you tend to select, let us assume that you have 10 patients. So now we are randomizing that, meaning that every first patient will go to the for example, group 1. Yes, every second patient will go to group 2. In this way, you are saying that you are not knowing which patient will go to group 1 or which patient will go to group 2. So this will reduce the risk of bias, that you are not favoring anyone. Or else what happens that once you know that which patients you are allotting it, now what will happen is that the more sicker patients will go to group A and the less sicker patients will go to group 2. So this can be avoided by randomizing the patients. Okay. So out is sampling bias. These are okay. These are all the similar kind of this thing, but most important bias is this Berken's bias, that once you take the patients from the hospitals as controlled, then this will lead to a Berken's bias. This is one of the most repeated asked question in MRCP. Okay. So you this taking a patient from a hospital, they will have more other disease, so that will reduce the outcome of the study. Okay. So the attrition bias. So what is sampling bias? Sampling bias is that if you want to study a particular population, if you want to go to a study and if you want to study about the incidence of diabetes in obese patients, let us assume that we can take this example only. Urban, or you're going to urban hospitals, but you're doing a study, but you're not taking anyone from a rural setup. So that will underrepresent the population from a rural setup, and you cannot extrapolate that study to a rural setup. So this will cause, you cannot extrapolate it to a real world scenario. So this is called a sampling bias. So how will you reduce the the bias is that you go to a rural and an urban, you do a random sampling so that all the patients from the rural and urban are included in that. So this is to reduce the sampling bias. So what is attrition bias? So what is attrition bias is that once you start a study, for example, cohort study, you can start with 115 divided into two groups. When you're following after 10 years, some of the patients will be lost. So maybe end up with only 30 patients in group A, this 50 will become 25, this 50 will become 30. So you're losing patients. So once you're losing out the patients, the final outcome of the study is compromised. So this is called as an attrition bias. This is then what you do is that I will deal again. I will teach you this in the next class. Okay, analyzing the data. What is intention to treat study? So you do an intention to treat study when you think there is an attrition is very severe. You do an intention to treat. I will let you know in the later. So what are the other biases? See, sometimes what happens is that there is something called when you're seeing that smoker, you take as it's a variable smoker. Okay, then you develop lung cancer. So this is the you want to study how many of the patients who are smoking are developing lung cancer. Now, what will happen? Most of the smoker also can be alcoholic, right? So now when the study is done and you say that the smoking is causing lung cancer, some other some other people will come and say that no, the patient is also alcoholic, that is why it is causing lung cancer. Now you are confused whether the smoking is causing lung cancer. Yeah, it is alcohol is causing lung cancer. So this alcohol becomes a confounding factor. This is called as a confounding factor. This is again a frequently repeated question, MRCP. What is a confounding factor? A confounding factor is one which is associated with both the exposure of interest and the outcome, smoking. Because most of the smokers tend to be alcoholic. And again, lung cancer, the alcohol can cause lung cancer. I'm just saying an example. So this is called as a confounding factor. So how will you eliminate this confounding factor when you're doing a study? Anyone else? Anyone, can you say how can you eliminate a confounding factor? So now what I will do is that I will divide the group of smoking. I will take the history. How many of the smokers are alcoholic? How many are of non-alcoholic? Again, I will take a non-smokers. I will try to know how many are alcoholic, how many are non-alcoholic. And I will tend to match them. For example, I will show you the similar. So once there is I'm just showing a NEJM article where the remdesivir, there is a tablet, okay, just the drug. This was a placebo. These were compared head to head to see which is better. So now what you can see is that they have equally distributed the group. For example, they have classified female 147% in here, it is 48. It is equally matched, meaning that there is no difference in both the population. So if you're taking the mean age of the females were 47% in the remdesivir group, again it is 48% in the placebo group. For example, now we are saying coexisting conditions, diabetes. Now there are 62% in remdesivir are diabetic. Again, in the placebo, 61% are diabetic. So now what you're doing is that now diabetes is a confounding factor, meaning that it can be associated with both the disease. Like patients with diabetes tend to develop COVID and it can cause more worse outcome in COVID. So now what we're doing, we match in the both the groups. So now the problem of confounding is cancelled. Like that, when the result is coming, you can say that I have put equal number of patients with diabetes in the both the groups, so that should not affect my study. So what is the how will you remove confounding is that you match them properly with the particular age or the particular characteristic of the patient. In a smoker, I will match them. I will put 10 alcoholic in smoking and 10 non-alcoholic in the smoking. I will do the similar thing in non-smokers also. I will put the same number of alcoholic non-smokers, alcoholic smokers, so that both group are balanced equally. If you don't match them, then the confounding will affect your study. Any doubt in confounding? So what is confounding factor? Confounding factor is something which is associated with both the risk factor and the disease. To remove the confounding, what you can do is that you can match them properly so that it is equally distributed in both the groups, that the confounding effect is eliminated. So the other, this is one of the bias. So how will you eliminate the confounding bias? Is by matching. This is one of the most frequently repeated questions in MRCP. So how you are measuring? When you are measuring the outcome, there are some problems with that. Okay, so these are very simple. It is not much asked. Observer bias. How will you remove the observer bias? When I know that I am going to, I'm just monitoring what is happening in the study, I will know that, for example, one group is having more of HIV patients. Another group is having less of HIV patients. Let us assume B group is having HIV negative and A group is having HIV positive patients. Now, if I want to know the incidence of tuberculosis, if I know that this group is having HIV more patients, I will tend to give the results more of the incidence of tuberculosis more common in group A. So this is called as observer bias. So how will I eliminate the observer bias? Is by blinding. So this is another one of the most important questions in MRCP. How will you eliminate the observer bias? It is by blinding. So once you blind it, you cannot know which patient is distributed in which group. So it is called as single blinding and double blinding. I will be discussing when I come to RCT. Okay, so single blinding is the patients will not be knowing which group they are distributed. Double blinding is that the analyst also will not know which group the patients are distributed. So both of them don't know what is happening. That is called as a double blinding. So double blinding, what it will help? It will increase the outcome of the study. Confidence of the study is increased when you are blinding them. Okay. So measurement bias is okay. It is very simple to understand that if you are using a faulty BP cuff, then you will going to get a wrong reading. So you have to do with a calibrated instrument. Okay. So these are some biases which you are going to encounter. The most important bias is observer bias, and the other important bias is confounding bias, and the other important bias is selection bias, Perkins bias. So once you get a Perkins bias, you need that it is hospital-based bias. So attrition bias, I will later explain when you're doing the analysis in RCT. Okay. Okay. So this is the confounding bias. I will just say that a third factor distorts the exposure outcome. For example, smoking confounds coffee lung cancer relationships. So now what you do is that you distribute equal number of coffee drinkers in both smoking and non-smoking. So that effect is eliminated. That is called as matching. Okay, fine. So now there is a lot of bias, right? Now I am talking about matching, stratification. I'm doing about a multivariate analysis. I'm talking about blinding of investigators. So when I incorporate all these methods, now I get some other study which is called as a control study, because these things are not controlled in a case controlled or a cohort. So now I want to conduct a study more efficiently. So now I go on to a next study which is more which give more confidence. This is called as a randomized control study. Okay, this is a control study. So most frequent repeated questions, randomized control study. So what I do is that now everything is controlled. You exactly know what is the exposure, what is the risk factor, what is the dose of the risk you are giving, how long you are going to follow, what are the side effects they are developing. You will have a diary, and You will have a record of everything what is happening, and everything is prefixed. Nothing you cannot do. Once you start the trial, you cannot go back and change everything, okay, until you have a special permissions. So this is called as a randomized control trial. So what I will do is that most of the randomized control or trials are done to the drugs, new drug experiments. So let us assume that I have a drug for a diabetes, a new drug I am detecting for diabetes. So now what I will do is that I will take 100 patients from a population. So treatment group, I will do what I will do, diabetes, 100 diabetic patients I will take. I will divide them into equal group, 50-50. 50 and here and 50 here. So among these 50, all the factors are matched. For example, among the 50, 25 will be male, 25 will be female. Again, I will do the same thing here. 25 male, 25 female. So among the other, okay, so this is one of the group. The other thing which I will do is that I will take 40 patients with HbA1c more than 10. 10 patients with HbA1c less than 10. I will do the same thing again here. I will take 40 patients with HbA1c greater than 10. Again, I will take 10 patients with HbA1c less than 10. Why I am doing is that I am matching it. Whatever I am taking here, what is the pattern of patients here? I am doing the same thing here. This is called as matching. So why I am matching is that to eliminate the confounding. Later, someone will say that since you have included more diseased patient in that is why it is causing lesser effect in that particular group. So now you say that it is equally matched, so that you cannot say that the results are erroneous. So that is why you do a matching. So now what is called as randomization. So randomization is that among the 100 diabetes patients, I don't have a say which patient will go to treatment group, which patient will go to control group. So by randomizing, you are avoiding the selection bias. Okay. So you don't know what is happening and which patient is going to that group. But how will you know that 40 patients with more HbA1c of greater than 10 only will go here, and the 40 patients for only 10 of HbA1c less than 10 will go here? So now what I do is that I do stratified randomization. Stratified randomization. What is mean by stratified randomization is, once you have 100 diabetes patients, I already have a list. I will prepare a list that I will take 40 patients with HbA1c greater than 10. I will take another 40 patients with HbA1c greater than 10, and I will allot this as group A and group B, and I will randomly put this group B into treatment group or group A into non-treatment or control group. So this is called stratified randomization. Stratified means you classify the patients into multiple different strata based on, it can be sex, it can be a disease severity status. So this is called as randomization. This is called a stratified randomization. Once you match, that is something different. Randomization is different. Stratification is something different. Okay. So the randomization eliminates the selection bias. Stratification will help to neutralize the confounding. Matching will also help to neutralize the confounding. So once you have divided the both groups, then you give an intervention. For example, I'm given the intervention drug. I'm giving the actual drug here. I'm giving the placebo here. And I'm following up, and I'm just seeing how many patients have a better control diabetes. For example, out of the 50 patients, let us assume that 40 patients are getting better control, but only 10 patients remain under still poor control. In these patients who are taking placebo, only 10 are getting controlled, 40 are getting poor control. Now you can see that the study is well controlled. Like, you chose the patients, you randomized them, you stratified them, you matched them to remove all the confounding factors, and you blinded them, because blinding means that these patients will not know whether they are receiving a treatment or whether they are in the control group, because these drugs, the intervention, the placebo and these drugs look similar. Like, they will prepare the drugs that they appear similar. Once you see from outside, both the capsules look similar. So this is called as blinding. So what is blinding is that they don't know, because once you don't blind that, they think that I am taking the drug, so I will getting better response. This is called as a placebo effect. So your blinding removes these effects. Patients will not know that is one blinding. The analyzer will, the whoever is analyzing, whoever is following up the trial, they will also not know that is a second blinding. So it is called as a double blinding. So I'm doing all these just to reduce the bias I have been talking about. So what are the bias I'm reducing? I'll just come back to the bias. Sorry, I'm just skipping it many times. So selection bias is reduced by randomization because I don't have the control whether the which patient is going to get the treatment, which patient is going to be a control. So the selection bias is neutralized in a randomized control trial. Sampling bias, again, I'm doing a random sampling. So the sampling bias is reduced. Attrition bias, you still can have an attrition bias in the randomized control trial because if the drug is poor taste, a lot of patients in the drug group will go out of the study. So this will become a problem. I will discuss this in later, okay? Attrition bias, yes, that's a problem in RCT as well, but we can just analyze in another approach. So matching, I told you, matching again, this removes the problem. The recall bias, again, the recall bias is eliminated because you're following up the patient. There is no chance that the patient is forgetting the data or anything. You are recording everything there. So you're doing it objective records. And observer bias, you're blinding the investigator, so you don't know, you cannot favor the drug group. So measurement bias, that it is okay, that you're doing it in a proper method, then it not be a problem, okay? So all these biases are eliminated or minimized in a randomized control trial. If you get one outcome in a randomized control trial, it means that it is very, very, very significant. So now that forms the basis of clinical evidence-based medicine. So I will just show you the hierarchy of clinical evidence-based medicine, okay? This is the evidence. So once you get from a case control study, I told you that case control study, you can only do association. You cannot prove causality. In a cohort study, yes, you can prove a causality, but there are a lot of bias in that. To eliminate the bias, to prove the causality, now you're doing a randomized control trial. Now, once you do a randomized control, you club many randomized control trials and analyze that, it becomes a systematic review and meta-analysis. You can see the evidence of information goes higher and higher. So once you get some evidence in case control, it is not great. But if you get that in the randomized control, yes, it's very significant. And that result is replicated in a systematic review, then it is very, very, very significant. Then this becomes class 1 evidence. That we will be discussing in the second part of the class, how to analyze all this. Okay. Any doubts till now? Any doubts? Anyone?
No, sir.
Okay. So I have discussed the incidence and prevalence. So I just touch upon incidence and prevalence. Okay. So whenever I will discuss it this later. It's not a very important. Cohort I have discussed. Cohort, okay. Retrospective cohort. It's very confusing with the case control study. And we have discussed about the formulas for case control and cohort. And we have discussed the Brad-Falls-Hills criteria for causation. The most important is temporality, meaning that the risk factor should precede the outcome. And drawbacks, I have discussed everything. What are the drawbacks? That is a bias. Basically, it is bias. And how to eliminate the bias? It's very important. Random. Now coming to the randomized control trials, I have discussed how we are eliminating the biases everywhere. Okay. Now we are going to the what is an RCT? So it is a prospective that you are going to follow up the patients after giving a tablet or a drug. It is an intervention study. So what is an intervention is that now you are putting a drug into the patients and then you are seeing it. So it is an intervention study. Now it is, I have told you all this. Okay, fine. See, so now what are we going in a drug development? Exactly what are the phases of drug development? I told you that most of the drug development are randomized control trials only. If you take any JM article, almost all of the studies will be a phase 3 trial or a phase 2 trial. You can go and see for yourself. It is a phase 2 or a phase 3 trial, randomized control trial. This is the trials which are published in most of the leading clinical journals, which will change our practice. So there are 4 stages there are actually 5. It is labeled as phase 0, 1, 2, 3, 4 in the drug development. So once in the phase 0, what we will do is that we will take a small number of volunteers or patients, and it is open label. We will tell the patients and that we are developing a new tablet and we want to know what is happening with the in the body. Now you say that, and then it is an open label. Open label is that the patient knows that they are getting the tablet. And then now what we are analyzing is that we are understanding the pharmacokinetics and pharmacodynamics. What is the half-life? What is the volume of distribution? So these are analyzed in phase 0. Half-life, volume of distribution, whether it is excreted through liver or kidney. So all these things are done in that. So once the phase 1 is done, phase 0 is done, you switch on to phase 1. So phase 1, again, it is an open label, meaning that you say, recruit the patient saying that we are testing these drugs. Hello. And then we do it in a small number of healthy or volunteer patients. Again, what you do is that you inject the drug and you say that what is the maximum tolerable dose. This is the most important. Phase 1, what you do is that it is safety assessment. Okay. Phase 1, you will know what is the maximum tolerable dose. For example, if you take a metformin, just saying like 3 grams, let us assume that 3 grams is the maximum dose that you can just tolerable dose. You assume that 3 grams tak de sakta hai. Then you switch this to phase 2. What is phase 2 is that now phase 2 becomes more of a randomized control trial. Now the patient doesn't know, the clinical investigator will not know what is the drug, who is receiving. Now you recruit lot of patients. So moderate number, you increase the patient size. You can see there are only 3. Now you will take around a lot of patients here and a moderate number, and it is randomized control trials. So phase 2 are always randomized control trials. Phase 3 is also randomized. So once you get, you do is that efficacy assessment. So what is efficacy is that does the tablet work? So what is it? Does the tablet work is that whether the new diabetic drug is controlling HbA1c significant when compared with the placebo or not. So this is what we are doing it. This is an efficacy assessment. So once the phase 2 is done and the results are promising, we switch on to phase 3. What is phase 3 is that you do the phase 2 only, but in a multicentric trial. You recruit more number of patients. You do it in a more, increase the data size. Okay. Now, what is the difference is that now you would have compared with the placebo. For example, you now compare, for example, semaglutide. If you take semaglutide, if you have compared semaglutide drug, this is a new drug for diabetes, okay, and weight loss. Semaglutide you have compared with the placebo here. Now, what you will do is that you compare semaglutide in phase 3 versus a standard care. What is the standard existing care? For example, standard existing care is metformin plus vildagliptin, just assuming it. Now you compare head-to-head semaglutide versus metformin with vildagliptin. So which is working better? So this is called a current standard of care or a placebo. You can do with placebo as well. I'm not saying that you cannot do with placebo, but most of the times you do with the standard of care which is existing at that particular point of time. So phase 3. So most important, the most questions are asked from phase 3 only. What is phase 3? It's a randomized control trial where you are assessing the standard of care versus this. Okay. Phase 1 is for safety. Phase 2 is for efficacy. Phase 3 is for effectiveness of against the standard regimens existing. And phase 4 is that once it is approved, after phase 4, the drug will get approved. So once it is FDA approved, then you tend to collect all the data after that. Then you say that, for example, semaglutide, now they are saying that it is associated with some retinal issues. Now they are collect the data, then they will see whether it is, you should give you a black box warning or not. So this is phase 4 of the study, okay? It's a post-marketing surveillance. Fine. Any doubt in the drug development? So drug developments are always randomized control trial. It is never cohort or something, okay? It's very important to remember this. So fine, we are done with this. So now we will go to some questions, okay? So anyone wants to, any doubts at this point? We will just have a short MCQ session of all these topics. Can I move to a MCQ?
Yes, sir, you can proceed.
Okay, so anyone, I just want a volunteer. So question number 1, can anyone say what kind of study is that?
Retrospective.
So can you say why it is retrospective? Okay, so now, yeah, please. So I'll explain. So what we are doing is that we are going to a hospital review of the record of patients who have taken proton pump inhibitor and those did not receive proton pump inhibitor over the last 10 years, and you're seeing how many of them has developed CKD. So
So why not case control?
now what you're doing is that you're going and reviewing the record of the patients, and then you're seeing then how many of them developed a kidney disease. Now you're not. Now what you're doing is that, see, you go into a record, okay? The record, you know that who are taken positive proton pump inhibitor plus you have not taken, then 10 years have already lapsed. Now some people with proton pump have developed CKD, some have not developed CKD. These people also who have not taken proton pump inhibitor, CKD positive, CKD negative. Now what you know that these people have already developed CKD. So now what we are standing at this point of time. At time we are here, but we are going in back and you review the record and you are going it in a futuristic way, in a prospective way. I mean, you're going in a forward way. Now I don't have a control here. Now what I'm doing is that I'm not taking a control here at this point. If it is a case control, what I will do is that I will collect CKD positive patients. I will take CKD negative patients, and then I will go on to ask what were the tablets you were taking. Now someone will say, then you find it out that these people with CKD who had CKD at this point, I was taking a pantoprazole for a long time. They say that, then they say that plus minus. Now they say that CKD don't have CKD. They say that I had pantoprazole plus pantoprazole minus. Now, if you are asking going the retrospective way, it is a case control now, but we are going to a record and then you are following up the patients. You're getting my point, what I'm trying to say, right?
Yes,
And
sir.
how many developed CKD? You are going back, you take the record and then you divide into two groups and then you follow them and then you see how many developed CKD. So that is a retrospective cohort. It is not a case control. Anyone of having doubt, because at this point I am not taking any control. Control is here is normal patient, and then I am not going back in the history and asking them whether you have taken pantoprazole or not. I am going ahead of time. I'm taking a record and then seeing who had taken proton pump inhibitor, and then I'm following them. Right? It is a retrospective cohort. Okay, fine. I hope there is no doubt, but be very clear with this concept of retrospective cohort versus case control. Okay. So the next question is, this is a tricky question. Anyone volunteer? A study compares 120 patients with peptic ulcers. So what I will do is that first I will construct a table. Now what I will do is that this is the disease plus disease minus. यहाँ पे I will do risk factor plus risk factor minus. Okay. So what is the disease? Peptic ulcer, right? So 120 patients with peptic ulcers to 120 without peptic ulcer. So disease 120. So disease total is 120. The disease minus is also 120. Fine. So 90 cases and 45 controls report regular NSAID use. So the risk factor here is NSAID use. So how many of the cases? 90. So 90 will come here, right? So 90 of the risk factors develop the disease, and 45 controls had also developed, had NSAID use. So the risk factor was positive in the controls of 45 as well, right? So how will you calculate this remaining? So I know that the disease is 120. I know that the risk factor is 90. So if you minus it, I will get 30. So if you minus from here, I will get 45 plus NSAID, right? NSAID negative. So 120 minus 45, I'll get 55, 75, right? Is there any confusion how I'm calculating? This becomes A, this becomes B, this becomes C, this becomes D, right? Should I repeat it? Anyone can say the odds ratio formula? Odds ratio is the cross product. You have to multiply these two and divide by these two. Like it is A into D divided by B into C. So it is 90 into 75 divided by 30 into 45. Right? So if I simplify it, I will get this is 2 and this is around 2.5. So I am getting answer as 5. So what I'm saying is that answer is 5, right? So meaning that the odd of peptic ulcer patients taking NSAID is 5 times greater, right? This is what an interpretation is. So see, basically they will give you the data. The problem is that you have to construct a table. So how to construct a table? I will just, if you're confused again, I can do it. Okay. So how will you construct a table? This is one of the very important thing. Just be very careful with how to construct a table. So the table, you will have the disease part here, right? Here will be the disease part. Sorry, it will be the disease plus it will be the disease minus. This is risk positive, risk negative. This is A, this is B, this is C, this is D. Okay. Now what they have given is that there are 120 patients with peptic ulcer. So they have given the sum, A plus C ka sum they have given, which is 120. A plus C is equal to 120, right? So 120 without control. So being that B plus D is also 120. Now they have given 90 cases. 90 cases have NSAIDs, meaning that out of the 90, out of that 120 with the disease, 90 had NSAIDs. So I will be A, this will be 90. So how will you calculate C? You know that A plus C is 120. So you subtract A from the A plus C combo, you will get 30 here, right? This is how you calculate it. You know that the B plus D combo is 120. You know that 45 controls had NSAIDs, meaning that the patients who didn't have disease, out of that 45 had a risk factor. So the remaining is 75 here, right? This is how calculated. So make sure that constructing table is one of the most important part in calculating this. Don't make a mess out of it. If you put the risk factor here, if you interchange the table here, you will end up with the wrong values. So this is a cohort study. Okay. So now what will you calculate in a cohort study? How will you estimate the risk? It is relative risk. Okay. So what is the formula for relative risk? It is simple. Okay. The relative risk is calculated by the incidence among exposed divided by incidence among non-exposed. What is the incidence among exposed? So what is that? 50 out of 200 patients who took new antihypertensive developed dizziness. And 200 patients who did not take the drug, only 10 developed dizziness. So what I mean is that if you try to construct the table, again, you can construct the table also, or you can construct the okay. So what is the disease? Disease is dizziness. Okay. How many of them developed? You can just calculate the table, or you can do a simple formula also. So the disease will be here. Disease plus, disease minus, risk positive, and risk minus. Risk is, what is the risk is? The tablet who have taken tablet. Disease who develop dizziness here. What are the dizziness? So 50 patients out of 200 developed dizziness. So totally how many are them? The disease had 200. The total disease is 200. So out of that, only 50 develop with the risk factors. Okay, so 50 here. So 150 will be here, because you know that the sum total number of total disease is 200. You know that 50 developed had a risk factor. So 50 and 150. Now what you will do is that what you will do is that only 10 developed dizziness among the 200 who did not take the tablet. Sorry, I just So what are the incidence among exposed? That the incidence is 50 out of 200 divided by who didn't develop the relative, sorry. Ten divided by 200, right? So if you simplify the formula, it is 200, 50 by 10, you end up in 5. This is one of the simple methods of calculating, or else you can construct the 2 cross 2 table. So 50, 100, you will know that it is, and how many of them develop the disease is that. So if you consider the table, it will be so yeah, you know that the do 200 again, you know that control is also 200. 10 develop dizziness. 190. So this is the you constructing a table for a relative risk. Actually, for the relative risk, there is no need to construct a table because it will be more confusing. It's better to go and straight away to calculate the incidence among exposed by incidence among non-exposed. You know that incidence among exposed is 50 out of 200, and the incidence among non-exposed is 10 out of 200. So you calculate the divide, you'll get the answer as 5. Okay, fine. So in a trial investigating the effect of high protein diet on weight loss, some participants also engage in regular exercise, potentially influencing the outcome. So how will you reduce in this confounding? What is the answer? You know, you have that. Now what you are studying is that you want to know that what is the effect of high protein diet. This is the variable you are studying. What is the outcome you are studying? You are studying weight loss. But what is the problem is that some participants are also encouraged or are doing regular exercise. Now, once you have a weight loss, now some people will argue that since they are doing regular exercise, that is why the weight loss has slow occurred. Some people will say that high protein has caused the weight loss as. So now we are confused. Now, how will you remove the regular exercise as confounding factor? Anyone? Anyone? How will you remove the confounding factor? Anyone? Am I audible?
Yes, sir, you are audible.
Okay, so the confounding is done by randomization or matching. You can match also, or you can randomization. While doing, see the answer here, it is randomization because actually it is matching. It is written as wrong. It is matching. Now, what will you do is that you distribute the regular exercise group equally among the patients who are taking high protein diet and who are not taking high protein diet. So then the effect of regular exercise is matched. It is equated. So now it is this is removed. So the effect of confounding is removed by matching. Okay. So now the next question is that in a hospital-based study, between the link of chronic pain and antidepressant use, there is a falsely high association is found to between the patients with either conditions are more likely to be hospitalized. So what is the kind of bias? So once you have the word hospital, we are dealing with the selection bias, which is particularly the Bergensonian bias. Okay. So this is as simple as that. A pharmaceutical company is evaluating a new oral anticoagulant in 5,000 patients with atrial fibrillation and comparing with the standard therapy to evaluate the efficacy and side effects. So what is this phase? So I told you that phase 0 is pharmacokinetics. Sorry, it is phase 1, phase 2, phase 3. Phase 2 and phase 2 and 3, it is a RCT. And these are blinded studies. This is the study in which you compare with the standard of therapy, standard of care at that particular point to know this thing. So phase 1 is for safety, right? You know that what is the maximum tolerable dose, you calculate all this from the phase 1. And phase 2 is again a randomized in a small particular group. Phase 3 is more increase the number of sample size so that you get this. This is phase 3. A study finds a temporal relation between prolonged mobile use and poor sleep with consistent finding in multiple countries. So which criterion of causality is this not? Okay. Now you have said that there is a temporal relation between the prolonged, you want to find the temporal relation, meaning that you want to establish a causality. So among everything, the specificity is not needed, meaning that, for example, specificity is that if the smoking causes only one particular disease, for example, let's assume that asbestosis cause only mesothelioma. The specificity is not needed to prove a causality, meaning that, hello. Hello. Am I audible?
Yes, sir.
Yes,
Yes,
sir.
sir.
Okay. See, I just wanted to say that the question is a bit screwed up here. I'll just say that what is the most important thing that you will look for the causality? It is temporality. Okay. So basically just understand that temporality is what needed. Specificity is not needed, meaning that smoking can cause n number of risk, n number of problem. For example, smoking can cause COPD, smoking can cause lung cancer, smoking can cause a urothelial cancer, smoking can cause a laryngeal cancer. So to prove a causality, doesn't need a specificity, meaning that if you want to say that smoking causes lung cancer, doesn't mean that smoking should only cause lung cancer. It can cause any number of cancer, but only thing is that smoking should precede that particular type of cancer. So you don't need a specificity to prove a causality. Getting the point, right? Like if one disease, it means smoking can cause n number of disease. That doesn't mean that smoking is not associated with all those diseases. Smoking can cause n number of disease, but to prove that smoking causes all these cancer, a specificity is not needed. You just need a temporality, consistency, strength. This is what is needed in analogy. Okay, so specificity is the least criteria, and that specificity is not needed. You just remember specificity, it is not needed to prove a causality. Okay, in a trial comparing two treatment of eczema, neither the dermatologist evaluating the skin improvement nor the patients know that which cream they received. So what is an example? Here the patients are also blinded, the physician is also blinded. So this is a typical example of double blind. So what is a triple blind is that? So patients are blinded, physicians also doesn't know which cream they are giving, whether it is a placebo or it is a treatment. Now the analysis group, once the data is giving, the analytics team is also not knowing which is the data, like which particular data, whether it is a treatment receiving, who received treatment, or actually who received a placebo. If they are also blinded, it is called as a triple blinded study. This is single blinded, this is double blinded, this is a triple blinded study, right? Okay. So it is now the particular example is a double blinded study. I told that comparing which I told you, okay, double blind study. Okay, this is the last MCQ for the day. So what is the mortality rate? You're calculating a mortality rate. So mortality rate is very simple. In a population of 10,000, 200 people die of a specific disease and 50 of them die from within it in the same year. Okay. So what is the mortality? So okay, the mortality rate is the mortality, how many of them are dying of that particular and divided by the population. So 200 develop the disease, so they are not dying. So you cannot use them in the denominator. What is a death number divided by population number? So how many of them are dying is that 50 are dying out of the population. So what is the population is 10,000. So which is divided, you get 5 in 1,000. So meaning that the mortality rate is 5 in 1,000. This is the mortality rate. If you ask what is the case fatality rate, what is case fatality rate? How will you calculate case fatality rate is that what is the number of death among the particular disease? For example, 50 died out of 200 who develop the disease. So now the case fatality rate is 25%. I'm meaning that if 4 people develop the disease, 1 is going to die. So meaning that 200 develop the disease, 50 died. So meaning that every fourth patient is going to die. So the mortality rate is given by another formula, which is death by the population. By the case fatality rate is given by the number of patients having the particular disease. So this is very important. So mortality rate and case fatality rate, they are frequently repeated questions. Okay. So I will just wind up the class. I will just try to say the relative risk session we will discuss in the last ones. Okay. So coming to this, these are the questions. So we have seen about the incidence and prevalence. So how will you calculate the incidence? Incidence is calculated from a cross-sectional, prevalence is calculated from a cross-sectional study. Incidence is calculated from a cohort study, because you tend to follow up the patients to find the incidence. Prevalence, cross-sectional study. Okay. Case fatality rate I just discussed. Mortality rate I discussed. And incidence and prevalence, the MCQs can be asked as numbers also. It is very simple. Just understand the concept. Prevalence is that at particular point, how many patients are having that disease. Incidence is that every month, how many patients are developing the disease. The measures relative risk, we do it for cohort. Odds ratio, you do it for case control studies. Odds ratio formula is very simple. You multiply the cross product, AD by BC ratio. The relative risk, it is the ratio of incidence in the exposed divided by the incidence in the not exposed group. So it is basically a ratio of incidence in the both the groups. This I will be discussing in the later thing. I have discussed about the cohort. I have discussed about the case control. I have discussed about cross-sectional and the randomized control trial. I have discussed about the bias. So this is very important. Go and read the bias. Confounding is very, very important. I remove the confounding by matching and stratification, but most important is matching. Okay, confounding and matching I have discussed. So I have discussed 1/3 of the 1/3 of the syllabus. The next is very important. I will discuss in detail about the statistics test, the confidence interval, and the graphs. So this is the next topic for the next class. The diagnostic sensitivity I will discuss in the last class. Okay, I know it is very boring, dry topic, but there is no other option because it's one of the frequently repeated in both MRCP part 1 and 2. Any doubt, just let me know, and please give the feedback also. If I'm very fast or something, let me know all that as well. I will slow down in the next session. So any doubts for this in this particular session?
No, sir. So far, no doubts.
Just give me the feedback as well. Okay, it's because it's very dry topic, but see, once before going to the exam, just remember these topics very well. Okay, so you will be getting the questions from this slide only. So just make sure that you are very sure about whatever it mentioned is in this slide.
So can we get the PPT that you are teaching from so that we can revise and
Yeah, I
recall?
will share you the PPT, the actual PPT. I have written something. I will give the original PPT. Okay.
No problem,
Sure,
sir.
sir. So please you send me the PPT. I'll share with the aspirants.
Okay. So anything else you want to say? Like if I want to go slow, or you want to repeat, or if you're
No,
getting.
sir. It's perfect.
Okay. Thanks. Anyone else? Any doubt? Okay.
So
So
I
just
believe the student doesn't have any doubts for now. So if any arises, we'll be having a second session, right? On 19th. We'll
yeah.
be discussing there.
The 19th, I will be discussing the statistical test. Okay, it is very important. They will be it's one of the most important for the general practice also. MRCP
Sure.
part 1 also. So please try to attend this. Okay.
Sure.
Okay. Thank you.
Thank you.
Any doubts? Just let me know, or else you can text in the group also.
Sure. Thank you, sir.
Thank you.